So we will be back to this point with Alfonso, with his talk, and now we should move to Puerta del Hierro.
Hello?
Hi.
Hello, Pedro?
Hello?
Can you hear me?
Yes, very well.
Okay, so finally we gave up the retro. We tried multiple wires. We were in the right position, in the right collateral, or at least the intended one, but the wires did not cross. We tried, if I can remember well, the XT, Fielder XT, the Suo, of course.
Xeon Black.
Xeon Black.
And Samurai RC.
Even the Whisper. And with no success in going through the corkscrew and the multiple tortuosities. It is true, it went like it opened in a fun way with several branches, and it was difficult to know which one of them connected, but it was certainly there was a connection. But even if we were in the right one, we could not progress. So we gave it up. I think it was a fair try, and right now we are anterograde. We are trying to do a wire escalation technique, and so what we've done, we could go on. We are with a Mamba catheter.
Mamba Flex micro.
Mamba Flex.
Yes.
We went in with a Xeon, and we are right now with a Gaia second wire. We have difficulty in going forward, so we're going to put guide wire extension that maybe we should have thought in the first place, but it is right now that we're going to do it. So, José Antonio.
Okay.
Any suggestions, please, are welcome. About the wire, the extension, if I may remember to you, if I may remember, or as a remembrance, we have AL 0.75 from Asahi, Iberian, 8 French, and with side holes, and that's as a guiding catheter. So we're welcome for your comments, and
we could see, as we know from the previous attempts, there was a bifurcation, and the proximal capsule was quite ambiguous. We can't see now in the angio from today, but we know that there was a side branch. Does anyone from the panel suggest that going directly with an ADR strategy instead of integrated wire escalation?
Well, yes, that's an option. We do have a very bad distal, a very short distal right coronary artery. I mean, the occlusion goes almost up to the posterior descending artery. We do not have a good re-entry point. So,
right now I am with the trapper balloon, as you can see in the scopy, and we are going to inflate the trapper balloon to trap the wire. Infla 8. So we trap the wire, and it fixes the wire. So we now can retrieve the Mamba Flex without moving the wire, as you can see. This is for the people with less experience with CTOs. I know, of course, all the people in the panel know this technique, but for people who is watching us through Wonder Medical, I think it's a useful maneuver. It's very sure. you fix the wire, so you give an extra safe to your procedure. And now we are going to use a Guidezilla, right?
Yes.
Yes. We're going to use a Guidezilla from Boston.
Just a minute. That's 8 French. Would you like...
8 French, yeah.
French.
A Guidezilla 8 French to have an extra support.
Yes, I probably you could argue for a smaller one, but this is an 8 French.
Yeah, we have a H-frame catheter, so we are going to use...
The problem with this is if it will go in the right coronary artery.
Could you please play the first angio? While you're... Could you please put the first angio just to see where's the wire in relation to the artery?
The first angio, okay.
Yeah,
here you have this one.
Just to remember, yeah.
Okay.
Okay.
So you can see it's a very calcified occlusion. You can see calcium. I don't know if maybe with the loss of quality of the emission, I don't know if you can see it, but here we can see it is very calcified. So it's going to be tough.
Have the trapper in place, Juan Antonio?
Yes.
Yeah.
Sorry, which wire have you in the right coronary artery?
Okay.
Excuse me?
Which wire are you using here?
Gaia second.
Okay.
Sácalo, sí, porque si no, no cabe.
Yeah, por eso.
Mantén tú sujeta este. Yo voy a retirar.
Suéltalo aquí. Un momentito que se está yendo la guía. Sujétamelo aquí.
Be careful with the wire.
Ahí.
Let me go in with the wire just a bit further.
No.
Okay, so that was a failure.
Está desinflado, ¿no?
Sí.
Vale.
Esta tenemos la Gaia, necesitamos una opción para entrar y luego...
Sí, dame el eyeliner.
Espera un momento, José.
Pero vamos a meter el eyeliner también. So what do you think about the calcium and which wire would you use to... We're going to put with a Sion wire, we're going to go with the Mamba Flex to the tip of the occlusion, to the proximal gap, and then we are going to change with the Gaia to the Gaia second that was quite successful to cross at least the first part of the occlusion. I don't know if you would choose the Gaia second as first choice, or would you choose another wire? What do you think?
Ahí está.
Vale, déjame el Guidezilla.
¿Quieres el Guidezilla?
Sometimes the Gaia wires. Sorry, please.
No, don't worry. But other option, if the vessel is very, very calcified, you cannot penetrate with other wire. A stiff wire type like Confianza Pro 12 or even Hornet 14 would be an option. But at beginning, I think Gaia second
Uno de 7 French, por favor.
wire for this type of occlusion.
¿No te pasa? Yes, thank you, Sole. The question about this right coronary artery is not only that it's highly calcified, but it's also very tortuous. So I think
yes,
it's
pilot
it is
200 or Gladius is other option.
Yes, that I think may be a good option. But the tortuosity, proximal tortuosity is a problem for using a very stiff wire.
But the proximal part is relatively easy, no? The problem is in the middle.
Yes, you're right. We have crossed with the Gaia till let's say the first bench of the recurrent artery, and now maybe when we cross this first bench, we move to another wire, like you said, the Gladius polymeric wire to advance through the calcium.
I don't have experience with the Gladius in very calcified lesions. I don't know. I would be, well, but probably because I don't have experience. I have experience with the Gladius, but not in such calcified lesions. And maybe it's easier for a Gladius to go submetimal directly. No, I don't know if you agree.
Espera que me voy a meter bien con el catéter guía.
We're having right now guiding catheter problems. I think there's a certain degree of fatigue, not only on the operator, but also on the guiding catheter.
Yo creo que estamos. Dame un toquecito aquí. No, con este.
Can you hear us, Pedro?
Yes, very, very well. So let us know.
So what do you think happened? This case is being a psychological challenge because we have to keep all the time the balance with all the strategies to be insistent, persistent, but to keep everything safe. So we have been trying first septal, as you saw, also second septal. At certain point we thought we were close, but you can see that they were not connecting. We tried 2 different septals and it was impossible. So we have moved back to the proximal gap and following the advices by Sole, we have changed our micro catheter to increase the support. We have tried with Hornet 14, which allow us to advance to the distal gap, and then we have switched to Gladius to perform a knuckle. So here you can see our micro catheter, the Gladius, and now we have the IVUS in place. This is live, and we are going to show you the IVUS. Can we show the IVUS? So I start the pullback. You see we are in the distal part of the Gladius wire, and you can see that we are likely in a false lumen, and all the true lumen is between 12 and 2 o'clock, absolutely compressed. We don't see inside the artery. Now we start to see something, but it's very calcified. For re-entering here would be very difficult. I think we need to go more distal than where we are now. And this is live angio also. So we are still in the CTO, all the time in false lumen. We have had all the time the trap liner inflated while we were waiting for connecting with you to avoid the hematoma from growing more, but you see that it's already quite large. I have to say that the Gladius worked quite nicely. We were able to direct where we wanted with Hornet 14, and the dissection was good, despite, and we are in true lumen proximally now, the problem here is that we don't have any support. If we try to increase the support, we lose pressure and the patient is ischemic. So we are working, we did the knuckle without selecting the artery with the catheter. So I'm quite satisfied with being at this point. I did not expect to achieve this. So this part we already know proximally. I'm going to stop here, this IVUS. And I think we are going now to check with angio how far we need to go with the wire and try to do re-entering with the Stingray. What do you think?
Yeah, I think
this point.
Sí.
I think yes, if you could go further down, maybe you could re-enter with a Stingray.
Okay, then let's do a scene here. Adelante. We have the trap liner inflated again. Okay, we are almost in the cruise, so not the perfect position for re-entering. But I think it's the last option we can try. If we do not succeed with the Stingray, then at least it will be an investment. But I think we need to try unless you have another suggestions.
No, I will do the same. Try, and if not, investment.
Okay, then we keep trap liner inflated, abrimos el Stingray. I'm going to show how to prepare the Stingray.
You're going to change the wire, Nacho, or not? For a
I'm going. No, Gladius is providing me a great support, which is, you see the catheter is looking the other way. So I think I need the Gladius to arrive to the distal part, and then I will remove it, and I will try to do the punction probably with a Stingray wire. Normally I do with Hornet 14, but here I think I need something sharper. Vamos allí a la
I was wondering if
lo hacemos aquí.
give you more support than Gladius, but if you are okay.
So I want to show you in the meantime this table.
Alfonso?
Yeah?
You were suggesting another, which wire were you suggesting?
No, I used to advance
Medical 12.
with the Micro 12, but if
Yes.
good support with the Gladius, it's okay.
Yes. I used to also the Miracle 12.
Yeah, but he has a knuckle. This is different because he has knuckle. Using extra plaque, sure. Okay. The problem is
the knuckle is quite large.
Yeah, but it's not. This is not larger as we use in the Pilot 200. The knuckle from the Gladius XS is smaller than the Pilot 200.
Yes, but what we can see here, it's
but
large.
we have a lot. If you can stop in to review the IVUS, you have a lot of information for this procedure.
We are showing to you. Sorry, we are showing to you the table where our nurse has all the wires. Sorry for interrupting here, and he has this pencil where he has been writing all the names in case we need to use back another wire. So this is just for tips and tricks for nurses.
Yeah, this is a good point for two old of the team.
Y la llave de 3 pasos aquí.
In the procedure, because it's very important. The teamwork fashion. This is a good demonstration.
We are going to.
I'm going to show the preparation.
Okay.
So for the Stingray is a balloon, and you just need to connect. A ver, que me estoy equivocando aquí. So this is where the wire is going, and this is where we will inflate with the manometer. First of all, we need to do a good empty on the balloon, because there is a very small amount of contrast inside, which means that if we have a little bubble, we will not see the contrast. So, perdona, que me equivoco. So, I do empty 2 or 3 times, open. This step is very important. Again. And one more. Okay, now I have to fulfill with contrast. I'm going to connect just to put some contrast in the... Vale, dame un poquito de contraste para que se llene esto. Vale. So now I have a little bubble here. I have to remove it. Okay. So this is pure contrast. You can see 1 cc of contrast, I will open, and if we have done the empty correctly, it should descend to 3 milliliters. Okay, you saw it. So now we know that all the system is full of contrast. Okay. Y ahora conectamos esto. Vale. So now we are going to advance this. Y vamos a ir con la guía Stingray. I'm not so optimistic now with the strategy because we are in a bifurcation distally, but we need to try. It's the last step. Dame todo normal. No, es la que está dentro.
The problem is you have some calcification in the crux.
Por detrás.
Because if you can function in the safe way, you can probably to advance the Sasuke and to try to keep the procedure safe. It does mean that you are keep open of the distal vessel, because it's a good point, but okay,
so we are doing
trapping. It's a complex case.
So usually when we use ADR, we keep this as a last option, and this is why all cases are very complex. The strategy itself is simple, is intuitive, but the cases are not.
Yeah.
Vale, deshinchamos el trapliner. Esto. Uy, espera que... ¿Cuándo es el último ACT? So there is some thrombi in the watchdog, and I want to make sure.
Oops. Oops.
Vale, sujétame la
dedo. You have a lot of gear in your indoor catheters, okay? Tape liner.
Yeah, and we have been inflated to avoid the hematoma from growing.
Yeah.
So you see the balloon now.
Yeah.
I'm going to advance as far as possible. I need to advance a little bit more, so I'm going to knuckle a little bit more. And I'm removing my wire now. Okay. And I'm going to inflate again the trap liner now, just to keep it in place. But Stingray wire. So now we need to inflate 4 atmospheres.
Nacho, can you choose the projection to see the overlap of the balloon, the point of the balloon?
Yeah, so I have to inflate and then I change the projection. So just 4 atmospheres.
Okay. That's okay. That's perfect. The good position. You have reached a good position.
Okay. Actually, the position here seems okay because we only see one line.
Okay. That's perfect. That's perfect.
¿Está bien, señor? ¿Está todo bien?
No.
It advanced quite easily, you know.
I'm just going to check if
you have a very subintimal space dilatation. There are a lot of space.
Yeah. So you can see that in other projections,
we have seen it in the IBUS.
We see the 2 lines. We need to find one where we only see one to go up or down. And the one where we were was perfect, I think. So here, let me do an scene here.
A lucky man.
Hacemos una
be a lucky man.
Va. So I'm going to inject. Okay, it's a very bad place for re-entering, but we need to try.
You are so far. No, don't you think so?
It's very far from the true.
You are very far. This is the knuckle. This is a big knuckle.
Yeah.
You have a.
But still, you agree? So. I need to try, right?
Yeah, sure.
Not sure? You think it's dangerous?
Sure. Yeah, sure.
Okay. I just need to clear the direction I need in my wire. So I will point up and see what happens. So as in the beginning, my plan was to use, the simple trapliner. My plan was to use Hornet, but since we are quite far, I need something more sharpy. I have these problems with this bending.
Yeah.
Oh, shit. It's kinking the Stingray balloon, the catheter.
There is also an opinion from the audience, from Dr. Walter Linus, who tells, and he's telling that obviously you should try, that you are making a very good work, and you must try even if you are far from the lumen.
Yeah, thank you, Baltasar. This is, you see what's happening, right? The catheter is kinked, and I'm just trying to redirect. Ana, puedes tratar de avanzar la guía, a ver si pasas. So we are trying to work together here and trying to diminish. Oh! So this was my fear. Okay. So we lost the position. The Stingray is still in the artery, but of course now everything has moved back. So I have to remove everything. And I'm going to do something, because we had some thrombi in the watchdog key here. I'm going to remove completely my catheter and flush outside. And then we go back to the artery and we see how it is. And maybe we need to stop, or maybe we find a completely different artery. So I'm going to remove everything. First.
Okay, Inácio.
This is a very good point. Okay, you need to stop and to watch what happened.
Mm-hmm.
Yes, but probably you will take some time to.
Yeah.
So maybe.
What's a very good point? Can you zoom here? I think this thrombus was in the thumb. This was not in the artery, but in the watchdog. But when I took out my other way,
I couldn't see.
A thrombus here.
Yeah.
Okay. So
fortunately, it's not in the.
We are over 300, but of ACT. But
this is
okay. So I think we are going to flash everything and see again the artery. I want to know how is this right coronary artery. Maybe we need to stop, but at least a final look. ¿Has lavado? ¿Has lavado, Jesús? Okay, I don't know if in Puerta de Hierro have been more lucky than us, or maybe we are moving to the next presentation. What's next, Pedro?
I think we should move to the presentation, yes, before going to Puerta del Hierro. Okay.
Okay.
And so I think that we can have Dr. Soledad now to make his presentation. I think the issue is already solved.
Can you see my presentation?
Yes.
Finally. Okay. Thank you for the invitation. I am focusing on aortosteal CTO because although aortosteal and cybranch ostial occlusion both shares common technical difficulties, in other respects are they quite different from one another, and we will have them time in this presentation. So, percutaneous coronary intervention of aortosteal CTO can be a particularly challenging lesion subset due to, among other factors, the lack of a good antegrade support, proximal gap ambiguity or unclear vessel course, etc. All these unfavorable characteristics which are very frequently present in such lesions. As a consequence, the technical options to recanalize the occluded segment are commonly limited, and a retrograde approach is usually required. Moreover, they can be heavily calcified, hindering antegrade or retrograde guidewire penetration. So, in my opinion, that is one of the most difficult type of CTO from a technical point of view. This case is a clear example of the complexity of this type of lesions. This CTO was failed twice for us, and the third time was failed by a well-recognized Japanese CTO operator. Despite that, the orthostial location is not an item usually included in the different scores used to predict the possibility of technical success. In this slide, we have summarized the different scores, the most used scores in the clinical practice. And as we can see here, only the Castle score integrates the absence of stamp. However, the specific orthostial location remains absent from available predictive tools for procedural failure. For all the reasons, we thought that it would be interesting to analyze the technical aspects and the outcomes of orthostial CTO PCI. For that, we performed a multi-center registry, which results have been published in REC. Patients undergoing attempt orthostial CTO PCI at these 4 high-volume centers were included in the registry. A total of 103 patients were finally included, and this number represents about 8% of the patients with CTO treated in these institutions. Orthostial CTO were divided into 2 groups. Those with a minimal proximal cap, we considered 5 millimeters, and those with total absence of up stamp at the aortocoronary junction, named flash orthostial CTO. Obviously, this lab subtype is the most hostile scenario for PCI. In this slide, we can see clinical and geographic characteristics of the study population. These occlusions were found in patients with an extensive comorbidity burden and high prevalence of risk factor. And geographic characteristics were also quite unfavorable, reflected by a mean GCTO score of about 3. Among them, blunt or ambiguous stamp was observed in most of the patients. It's important to highlight that flash ostial CTO was present in about 1/3 of the patients, arguably the most adverse feature in a CTO. In line with the complexity, the technical success was 77%, clearly lower than those reported in large registry with all comer in CTO. The most successful crossing techniques were retrograde techniques. In part is logical because orthostial location hampers coronary engagement or the support is poor. So a retrograde technique can be most effective or only the only alternative to cross the occluded segment. In flash ostial CTO was still more evident. As we can see here, a retrograde approach was required in a higher proportion of the patients. These percentages, as we can see here, are well above the figures provided by large contemporary registry in which antegrade techniques were predominant. We also observed a trend toward a lower technical success rate in this complex group. It's not rare that the absence of interventional collateral was a factor associated with a higher risk of technical failure, underlining the importance of a retrograde approach to improve the success rate. However, the concept of interventional collateral is a subjective criterion, as we have seen in the cases today. Collaterals initially considered to be interventional later proved to be uncrossable and vice versa. Additionally, invisible collaterals can be crossed with surfing techniques. So a priori, it's difficult to know in most of the, at least in a high proportion of the cases, if collaterals are interventional or not. With respect to the clinical outcome, procedural success was 76%, and the rate and the complication rate globally was almost 8%. The most frequent complication was pre-procedural myocardial infarction, but only in 2 patients was associated with coronary perforation. The remaining 4 patients, that it was an asymptomatic event without clinical consequences. There were 4 coronary perforations treated successfully with cover stent implantation and without cardiac tamponade. 1 patient had a stroke, no patient died in the hospital. So we can say that the technical success and procedural success is lower than in other types of CTOs, but the rate of coronary complications, serious complication, was acceptable. This is an algorithm proposed by Abraham, designed specifically for the treatment of right coronary artery CTO. As we can see here, the first step is to determine if the coronary can be engaged with the guide catheter and if the guide catheter provides adequate support. If the coronary, if the CTO cannot be engaged with the catheter, for example, in flash ostial CTO or in ostial intra-stent CTO with protruding stent into the aorta, or the catheter doesn't provide adequate support, a primary retrograde approach is required. So in summary, the 2 key points in this type of lesion is the antegrade support and the presence or no of interventional collaterals. Finally, sometimes it's difficult to introduce the guide wire, the retrograde guide wire, directly in the guide catheter. So in these situations, we need other alternatives we will see in the following examples. Here we have a case of a flash ostial right coronary artery CTO with very good distal filling by channel collateral. So we planned a retrograde approach here through this stat channel. This is the path of the guide wire to the PDA. A pilot 200 crossed the occluded segment, passed to the aorta. Once the pilot 200 was in aorta, the micro catheter was advanced, and the pilot 200 was exchanged by a RG3 guide wire, which was snapped, as we can see here, and pulled out through the sheath, as the video showed. Finally, a 8-frame multipurpose catheter was advanced and the circuit was performing, completing the PCI. This is the final result, excellent final result. This is another example of a flash ostial right coronary artery CTO with tortuous septal channel, but adequate filling. And in this case, we also planned a retrograde approach because of total absence of stent, as we can see here. This was the septal channel chosen. It was tortuous, but a suo wire could advance. Several attempts trying to pass to the aorta were made, even angio-guided, And finally, a Confianza Pro 12 cross to the aorta, as we can see here. Once the correct position of the guide wire in the aorta lumen was confirmed, the microcatheter was advanced. In this case, we used a modified externalization technique, as we can see here. A multi-purpose, 8-frame multi-purpose catheter was introduced, and the RG3 guide wire was introduced directly in the catheter. It's not always easy because sometimes the RG3 guide wire goes directly to the carotid artery, but if possible, is quite simple, simplify the procedure. This is the final result, a good artery. And this is the last example, another flash ostial, CTO of the right coronary artery, the same problem, total absence of stump, impossibility to engage the coronary artery. Again, a retrograde approach was planned. A Confianza Pro 12 passed to the aorta, crossed to the occluded segment, passed finally to the aorta, as we can see here. But the problem here was the microcatheter was unable to advance from this point. A possibility will have to snare the wire, but the problem with stiff wires is the hook effect and the impossibility to remove posteriorly the guide wire. So it was decided to risk to remove Confianza Pro 12 and use a pilot 200 that fortunately was able to advance and passed again to the aorta. The pilot 200 was snared, as we can see here, and additionally trapped with a balloon. The applied tension allowed for the microcatheter enter, as we can see here, enter the antegrade catheter, allowing to do the circuit and the PCI. During all this maneuver, it's important to keep an eye on the left catheter to avoid the risk associated with deep intubation in the left coronary artery. And it's also important to pay attention to the potential risks of collateral rupture when due to the high shear stress when pushing the microcatheter out the right coronary artery. In this case, everything was okay, and this is the final result, an adequate final result. Finally, in conclusions, orthostial CTO have high complexity, often requiring use of the retrograde approach. The presence of interventional collaterals seems to be key for the achieving procedural success. In our experience, the PCI success rate was lower than those reported in all comers with CTOs, although with acceptable low incidence of complications. In-depth knowledge of modified externalization techniques is needed to solve these cases. Thank you very much for your attention.
Thank you, Dr. Soledad, for your very nice presentation, very nice cases. I would like to ask the panel, if anyone makes to make some comment or to put some question. No questions.
I was guided attempt to cross the proximal gap. When you do it, I can interpret the images so well, but sometimes I feel difficult to direct the wire to the place I am seeing in the IBUS. Do you have any trick or something to do it well?
Sorry, Alfonso, I can hear properly. Can you repeat, please?
Yeah, of course. Regarding these ostial lesions, I was wondering if your experience in IBUS guided penetration of proximal gap. So because I have done not so many cases with IBUS, and I can interpret the images properly, but sometimes I feel some difficulties to direct the wire to the place I am seeing in the IBUS. So do you have any trick or something to improve these skills?
I agree with you. Inside branch ostial occlusion is easier because you can put the IBUS in the side branch and puncture the cap with the guide wire. In ostial, in aortostial occlusion is more difficult because the problem is to engage the coronary artery mainly in flash ostial CTO. In this situation, we haven't performed any case because we haven't been able to engage the coronary artery. I don't have any special trick in order to put the wire in place, only in side branch ostial occlusion.
Thank you.
Did you create a new ostium in any case?
Yes.
Creating,
yes.
Yeah.
In right
Sometimes it's risky.
Yeah, but in right coronary artery is not too
not
risky.
a problem. It's not a problem.
No, but
it's risky.
The problem is
the left main, yes.
In the left main, yes.
Yeah,
in the left main, we have a case, very complicated case. Fortunately, the patient is okay. But in right coronary artery, we have create
some new osteum. Okay.
Some osteum, yes.
For abnormal coronary origin, do you have any tips and tricks? Do you use CT or?
Sometimes we have some doubt about the origin or the trajectory of the vessel. We perform a CT to understand the trajectory of the vessel, but in a few cases only. Okay. The problem is sometimes when it's a flash orthostial CTO, you need the retrograde guide wire goes directly. If not, in an antegrade way, you have very few possibility.
Yeah, it's very, very hard.
In fact, the success rate is clearly lower.
Yeah.
Mm-hmm.
Yeah.
Yeah, I was thinking that as João was telling in his presentation, the calcium is usually our worst enemy, but here it can be our friend, because if there's calcium in the ostium, at least we know where we should be, because sometimes you even don't know where's the ostium, and the calcium can help somehow to try to penetrate if it's not possible to go retrograde. Well, I don't know if anyone wants to make some other comment.
I think they want to connect from Puerta de Hierro to show their case, Pedro.
Yes, I was going to ask you, maybe we could connect and then you but then you will give us some news. Okay.
Jose Antonio, we have you live.
Okay.
Hello.
Hello. We are going to tell you we have we were stuck in the right coronary. So we improved the support with 7th Gaetzilla. We were with the Mamba Flex as a micro catheter, and we tried first to advance with the Gaia 3 that we couldn't advance far from the proximal cap, and we changed to a Gaia 2 that we were able to advance, as you can see there, after the first curve of the right coronary artery. We are quite sure we were not in true lumen, because here you can see the calcium. We are outside the calcium. We are probably subintimal, but at this point we couldn't advance the mamba to improve the support of the wire or to change the wire. And at this point, we were talking, Javier and me, that we already have 6 gray of radiation, 600 milliliters of contrast. So we decided to stop here before going ahead and have some problems for the contrast or radiation. The patient is right now he's okay. He's perfectly well, but we think the safety of the patient is the first thing we have to keep in mind. So we have to stop here with the opinion of Javier.
What we didn't say at the beginning is that we talked this morning with the patient for about 10 minutes and told him that we were going to take a safe approach and not put him in a considerable risk. I think we still have room for medical management, and even though we could have gone on and did an investment procedure and inflated the balloon, but we thought that we were going to spend more contrast and use more time and more fluoroscopy. And I think it is wise, as when you are going up to an 8,000 meter mountain, to know when to stop. And that is what we've tried to do. And I think it's a good teaching point to put your limits. We had put our limit in 10 grays. Considering both procedures, we have exceeded that, 11 grays. And I think it's best for the patient, and we can reconsider it at another point. In order to
this is the final angio of the coronary.
Jose Antonio, could you do like a summary of the entire case, all the strategies?
Yeah, sure. Okay, so we tried first retrograde. Okay, we tried first retrograde, and there was a first difficulty, that was the takeoff of the septal branch. We tried to serve, because it was a very sharp angle in the septal branch. So at first we couldn't enter the septal. So we changed. We use here we were using Corsair Pro Micro Catheter with a Sion wire. Then we changed for a Sasuke Micro Catheter, that is a double lumen Micro Catheter. So we advanced the Sion to a diagonal branch, and with the help of the Sasuke, we were able to cross to the septal branch that we wanted to try. Here you can see the advancing the wire. So we already were in the septal, but unfortunately we couldn't go through septal. We tried several wires, Sion Black, Samurai RC, Whisper, of course the Sion. So we didn't succeed with the retrograde approach after quite a lot of contrast and radiation. So we moved to antegrade. We knew that if we failed retrograde approach, it was going to be very difficult to open the artery, because it's a long occlusion, very calcified vessel here. And in antegrade, we use Mamba Flex as micro catheter, and we tried with Gaia second and Gaia third. We had a small support of the guide catheter, so we enter a GuideZilla 7 French to improve the support. But even that, after the GuideZilla, here you can see we have this Gaia second, but we couldn't advance with the Gaia second. We changed for a Gaia third, and finally we changed again for a Gaia second, and we could advance right up to the first curve of the right coronary artery, but we are out of lumen. We are subintimal, as you can see here in the calcium. And at this point, we decided to stop because we already have a lot of contrast and radiation. The patient is okay, so we stop here. And now we are going to close the femoral punctions with ProGlide device. And well, that's all. I don't know if you have any comment or...
I have a question for all the experts, which I'm sure are more experts than ourselves in ADR. If you think this case would be suitable, maybe we can put the left coronary artery injection so they can see.
Okay, here you can see, this is the last injection in left coronary. You can see...
Ignacio, do you think, would you try ADR maybe in a second Pedro, anybody, Pierre?
Yeah.
I don't know.
So I think we selected both very challenging cases. And in this case, the distal right coronary artery before the crux seems very diseased, but also beyond the crux, the distal vessel is not so good. So, and there is huge tortuosity, much calcium. So I think ADR would be almost impossible in this case. I think the option was retro. You tried your best. You did a very good job, but it was extremely challenging. So I don't think ADR could solve the case.
Ignacio, you can see there is a little of hematoma, septal hematoma there, but the patient is perfectly well right now. But we try hard the septal branch, and that's the one of the consequences. But so right now this septal branch is unuseful. And I think I don't think it's worth to try again another procedure, because we have tried two procedures, were retrograde and antegrade, and it's really a difficult case.
Yeah. I don't know if anyone in the panel, Pedro, would do this thing different.
We can probably the safety strategy for this case is retrograde, because you have a lot of disease in this distal vessel, and you are going to have a lot of problems to good orient with the device-based, the Stingray, the crossbar. This is the first point. But you are unlucky to go a very interventional collaterals to the left, to the right. The second one, you have a very tortuous right, heavy calcified, and you have a long occlusion. It's not a good case, in my point of view, to try a lot of integrated wire escalation. Probably the best way is to do a knuckle. It's safer to feel very comfortable with the knuckle. But you have a lot of ambiguity. You need to increase your guiding support. You never have very good guiding support. This is clear. After that, you use the member. Probably you need a more supportive micro catheter, someone like Turnpike Gold, because you need support. You need to go forward. And after that, you need once again, you need to probably to do knuckle for to good high entry distally, because it's not easy, because it's a very long and very heterogeneous histopathology vessel. This is fashion as integrated wire escalation, in my point of view.
Well, we totally agree. Especially backwards.
Meantime, if you I have experience in IGR.
I cannot hear you. There is a technical problem.
I think the connection from Joao is not so good.
Oye, mira,
so apologies.
vete hablando y yo voy cerrando.
But maybe I don't know, Alfonso Sole.
The knuckle, it's safe, it can help you.
So Alfonso Sole, would you have done something different, a different catheter, a different approach, anything different that we could have?
No,
I think
sorry.
No, Alfonso.
Okay. No, I would
No.
add in
Tú habla.
anything else. It's a very difficult case. I would like to congratulate the operators for the patients, and probably the only thing is to change the micro catheter for a more supportive one. It's the only thing to try to advance it a little more distally, but it's a quite difficult case. So I would do the same at the end.
In my opinion, the case is very complex. And the only alternative is the retrograde approach. Occlusion are very challenging, and sometimes it's not possible to cross because a priori collateral will seems adequate, but later impossible to cross. In my opinion, the strategy has been adequate. I would have done the same. The problem is if you cannot cross the collateral, probably it's impossible to pass the occlusion, because in an integrated way it's really difficult because it's long, tortuous, and calcified.
Okay.
And I think the catheter, the problem is to pass the guide wire. If you don't pass the guide wire, the micro catheter is the second step, probably.
Yeah, but this, once again, this is a very heterogeneous vessel. Probably you need to work extra plaque, not into plaque, because it's a long calcified occlusion, and you have a lot of tortuosity, and you have a lot of calcification. For me, intraplaque, it's very, very hard.
Ponte unos guantes y manténlo.
I agree, but the problem is you don't have a place to re-entry, because the bifurcation is in close proximity with the occlusion. That's it, the problem.
I'm not sure about that, because sometimes this short segment before the bifurcation is enough to re-enter. The main problem here would be the calcium, because obviously it's much more difficult to re-enter with this heavy calcification. But I agree with that the retrograde would be the first option, but it was a very difficult septal, very with this corkscrew, and well, I think it's not possible to cross it. But I was asking in the beginning if we should go directly with a knuckle wire, because I agree with John that it's very hard with this tortuosity and this calcification to go and to be successful with a retrograde wire escalation. Obviously, it's a very challenging case. So even with knuckle, it would be a very difficult case. But probably it would be my second option. But anyway, it's not surprising for me to have a failure in this situation, because it's a very, very difficult case. And I agree with Javier that probably if this patient goes quite well with medication, probably I wouldn't try it again.
So maybe we can say goodbye for now to José Antonio and Javier Goicolea, and maybe José Antonio can join us in the chat. And if you want, Pedro, we can see also the summary of the second case, also failed, but not a very good day for us. But we chose specifically very challenging cases because we know these are the most educative, and that was the aim of the session.
Yes.
So, and maybe can we connect with the cath lab here in Valladolid, please? So the strategy, we have tried 5 different strategies. We started with wire escalation, then parallel wires with Sasuke as well, then retrogrades, and finally knuckle and ADR with crossbow Stingray. And we will show now what happened. Can we see the image from our cath lab? Okay. We start from the beginning.
You're not seeing yet.
Yeah. Can we see the cath lab, please? So the main issue in this patient was not exactly the support. The problem was that if we selected properly the artery or we use the trap liner, then we have ischemia. And if we have ischemia, the patient went very sick. It happened very early in the procedure. So you can see in the images that the catheter was out all the procedure. Are you seeing the cath lab?
Ignacio, maybe in this case, it would be better to have a 6 French guideliner. I mean, this after seeing what happened.
Yeah, it's a very good idea. Yeah. The only problem with that is if we advance the crossbows or only the Stingray, then we need trapping throughout. And if you have a 6 French extensor, you cannot do it. We could have tried to use an extension of the wire in that scenario. That was an option. Are you seeing the image now? Because I can see it.
Yes.
Yeah, you can see you. You can see.
Dr. Serrador, can you show the case from the beginning again, and then the panel can discuss? Okay, next. Let's go through this. So this was a guided function. We always try to do it when we use 8 French, like in the TAVI and preclosure. Here you can see that the distal vessel of the right coronary artery was good from the crux, but not so good in the distal segment. And we can see all the jailed septals. This was the Mamba with a Judo 3, where we were able to advance the Judo 3 through the proximal gap, but we stopped in the occlusion and we went to a Gaia 3 and a Judo 6, and were able to reach the distal cap. This is still the Mamba, and I think this is the Gaia. Yeah, we were quite close, at least in this projection. And here, in one projection seemed okay, but in the other one, we were clearly out of the true lumen. Well, this was clearly out of the vessel. So we pulled back. This was a branch, apparently. And here we replaced the Gaia. This is still the Gaia, but next is the Judo 6 here. And the Judo 6 was able to track the vessel quite nicely, but not beyond this point. That is clearly false lumen. So here we tried the crossbows, but as you saw in the IVUS, there was a lot of calcium here. So the crossbows, and with this lack of support, was impossible to advance. So then we started with the septals, and we tried first septal and second septal. Let's show all of them, please, from the cath lab. We did selective injection. We tried with Sion and also Sion Black, as suggested by Baltasar Lainez. In some images, we thought we were very close, but it was impossible. And probably this is because of the existence of 2 large epicardials that led to the lack of development of collateral. Then here we used a higher support micro catheter with the Gladius, and we were able to do a knuckle without having much support, which was really nice because we were not selective, but you can see we pushed and we were able to do the knuckle. And then we advanced it, we pre-dilated as suggested by Soledad. And we did the IBUS here. We saw that we were all the way in false lumen from the proximal gap. And here we have the knuckle right before the crux, and we decided to advance our Stingray balloon. We saw the preparation of the Stingray balloon. We saw a bad projection for working, this one, and the next one is a cranial projection, which was very good. And in the next one, we injected, and we saw that we were far from true lumen, but still it was feasible to do the punction with the Stingray wire. So I think this might have been possible. The problem is next prior one, please.
Sorry, Ignacio, did you try to re-enter a little bit more proximal?
Just prior one, please, la anterior. The problem was not, the thing is that here there was a kink in the catheter of the balloon, and I was unable to advance my wire from here. So when I was trying to reposition the catheter, even with the Stingray balloon inflated, it all went back.
Everything gets out.
So when that happened, the hematoma grows a lot, and then I have not tried anymore. And I have the suspicion that there was a thrombosis of the catheter as well. So I decided not to inject. We removed, and there was some thrombi in the watchdog key, in the key for angioplasty. We were very close, I think.
Yes. For sure.
And here I really consider this case investment because the patient is symptomatic even after the angioplasty in the left coronary. So I think we will try again, but maybe in a couple of months, or maybe in the next iCTO meeting.
Okay. Yes, I think in this case you can try once again. Okay. Thank you. So we can move now to the next presentation. So I will ask Dr. Ander Regueiro to talk about the wires in CTO, in calcified CTO lesions. Please.
Thank you. Hello, Alfonso. I don't know if it's okay with you. No? Okay. Okay, perfect. So I'm gonna share my screen. Are you looking at the presentation? Okay, well, first of all, thank you very much for the invitation. And second, well, to congratulate the operators. Those were very, very difficult cases. And those are also cases in which we learn a lot. So congratulations for that. And well, we'll see what happened with the patient at the next meeting. This is going to be a short presentation about guide wires in patients with calcified CTO lesions. So we'll cover these three topics. So the first question will be which criteria should be used when selecting a guide wire. The second is the current guide wire options for calcified lesions. And the third, the techniques beyond the wire. So which criteria should we use to select a guide wire? The answer for this question is that we need to use the same principles as with all other lesions. So to do that and to answer that, we need to see, as Dr. talked in the previous presentation, we need to see the anatomy of the patient, and we need to ask what do we want to do with the wire. Because as you all know, there are calcified lesions that are very different. For example, in the left angio, you're looking at a very, very long CTO lesion with tortuosity, ambiguity, and at the right coronary and the right image, you are looking at a very calcified LAD occlusion, but that is very different from the other one. So you are going to ask different things for for each guide wire, and depending on that characteristics, you are going to select the guide wire. So the main question when selecting a guide wire is, what do you want to do with the wire? And depending on the patient anatomy and the characteristics of the guide wire, you will need to choose one. So therefore, this is a brief summary. Obviously, you can do more techniques, but in order to simplify this talk, we'll talk about 4 different approaches or techniques. So we can select the wire. So first, if we want to do proximal gap puncture, we'll select one type of wire, or if we want to do knuckle or intraplaque tracking, or after we cross lesion to support after crossing the lesion. So for the first option, if we want to do proximal gap puncture, and this is the example of the prior CTO that we saw, we need a wire that has a high tip load and a taper tip. So with these options, with these characteristics, we have several options, and this depends mainly on the experience of the operator. But we have the Confianza Pro 12, the Hornet 14. We have this new wire from Teleflex that is called Warrior, or we can also use a peripheral wire in the coronary arteries that's called Astato, and it's also from Asahi. So the characteristics from the Confianza Pro, this is a very well-known guide wire. It has 12 grams as tip load, it's tapered, and the tip of the wire is 0.009 inch. So it actually gives you a little bit more, or a bit more of penetration force than a wire that doesn't have a tapered tip. The other wire from Boston Scientific, it's the Hornet 14. We have several options from Hornet, but actually I think that the one that we use the most is the Hornet 14. It has 14 grams at the tip load, and it also has a very, very tapered point with 0.008 inches that gives you a lot of penetrating force. This new wire, it's from Teleflex, that it's called Warrior, and it's also 14 grams tip load, but the point it's a bit different than the Hornet, and it's 0.009, just as the Confianza Pro. So we have these 3 wires that we use a lot, and it depends, as I said, mostly on the experience of each operator, but the characteristics of all these wires are very, very similar. So that's one option. The other option is that if we want to treat a patient with a very calcified lesion, and we know that we are not going to go all the way through the occlusion, that we need to go extra plaque or subintimal, then in order to do a safe procedure, we need to do a knuckle. So to do a knuckle for a very calcified lesion, long lesion, we're looking at the knuckle, and in this way we are solving the ambiguity of the occlusion, and we can finish the angioplasty. So we have for a lot of time mainly these 2 wires, the Fielder XT and the Pilot 200, and now we have I think that this is a game-changing wire, the Gladius. So the first one is the Fielder XT. You can also do a knuckle with the Fielder XT experience and the preferences of the operator. I prefer, in particular, the Fielder XT over the XTA. We remember that this is a 0.8 gram, and it's a taper tip with polymer, so you can do a very tight knuckles. And if we want to use a wire that has a bit more of tip load and do larger knuckles, then we can change for a as I said, there is a new option. It's not so new, but it's becoming more and more common. That is the Gladius. This one The main advantages of this wire over the others is that it has the Act1 technology in the core, so you can control very nicely the wire, and it also it's pre-shape. So for wires that are an advantage, and you can use this wire not only to do knuckle but also to go through the lesion and to do re-entries in reverse cart or to track the lesion after we do the puncture with a Stingray. The third scenario is if we want to do an intra-plaque tracking. Sorry, but I think that, yeah. So this is also a very tortuous lesion, but as you can see, there is seems to be a small channel, and there is calcium all the way through the lesion. So if we want to go intra-plaque, we will need to have a medium tip load with a special core, so we can have an actual good control and tactile sensation of the wire. You're looking here with the fine cross and a Gaia that we are advancing through the occlusion with a very good control of the tip, and we can go all the way through the occlusion and cross the lesion. So there are mainly two types of wires that we use. The Gaia wires that we all know a lot, the first, second, and third, and also more recently the Judo family wires. So the Gaia wires is a very special wire. We use this wire a lot. It has a micro cone tip, a composite core, and it's pre-shaped. And we have 3 different options with different type tip loads depending on the necessity of the penetration force. All of them have a taper tip. The first, it's a bit more tapered than the second and the third. And the tip load goes from 1.7 all the way to 4.5 grams. And the second family of wires that we are specially designed to track lesion through the calcium, it's the Judo family wires. We almost always use the third and the sixth, not also the first one. And this wire has also a hydrophilic cover in the tip, and they are tapered also as the Gaia family. Once we cross the lesion, we may need a lot of support to advance the devices. So this is another thing that we need to take into account when treating CTO with a lot of calcium. Most of these wires are the ones that we use all the time. So BHW, Ironman, or Grand Slam.
I think we lost Ander.
Yes.
In a bug, in a tunnel of slides.
Yes. Maybe we can reconnect.
While he reconnects, Pedro, I have a question for my colleagues, but I think Javier maybe wanted to make a comment.
Yes, thank you. Thank you, Ignacio. Thank you, Pedro. Sorry for interrupting. I have to leave. I'm sorry, I have to take a plane right now. So I want to say goodbye to everybody. Let me focus. Where am I? Okay.
Yeah, the other way.
I can't find myself. Okay. So just reconsidering what we have seen. No, we could criticize, or we could be very critical with the selection of the cases. We have selected both, and without any previous arrangement, we have selected very difficult cases. I think we all agree, and you have all been. And when you select very difficult cases, there is a certain possibility of failure, and that possibility may disencourage other people that are beginning. But my reflection on this is that the way, el camino, as we say in Spanish, is almost as important as the final goal. So in the way, we have tried to teach and to share and to discuss different ways of solving different problems. And I think both Ignacio and Jose Antonio and all the panelists have commented the ways to engage and to tackle the difficulties. And I think that is the important part. The second part is the safety. Never put your pride before the security of the patient. I think we both have stopped at a point where the safety of the patient is at issue. And I think both of those goals merit well the certain disappointment from 2 consecutive failures in a 2-lesion course. So that would be my reflection, Pedro, Ignacio, Jose Antonio. I think you can be proud, all of you, in directing, co-directing, and chairing this session that I think should be taken from the values that I think I've discussed right now.
I fully agree with you. Thank you. Well, we must deal with this. CTOs are like that. Sometimes we success, sometimes we fail, but safety is the main thing that we have to keep in mind. And I think that you both work very nicely. Beside that, we always learn, even with a failure. Sometimes we learn more with a failure than with a success. So I don't think that the cases were not well chosen. I think that were great cases, and you've done a very nice work. So I think that we all learned a lot, and congratulations for the cases.
Thank you for your wise comments, Javier. You are the voice of experience, and I don't feel disappointed for the case. Of course, we prefer a success, but I think we did things right. And of course, we can discuss a lot after about the case. Now, I think we should continue with Ander because he's back, and his talk is really important for, we have saw a lot of wires, but I think he has now to make the point why one wire and not other.
Yeah, hello. Sorry about that. I don't know what happened. Well, it's just a couple of concepts and it will be done. So I was talking about, I don't know where it stopped. The wiggle wire, it's a wire that we don't use a lot here in Spain, but it's used in Canada, for example. It gives you a lot of support. The disadvantages is that you need obviously a micro catheter to advance it, but it can give you a lot of support. And the next wire is the Sion Blue extra support. That the advantages is that you have the composite core of a Sion Blue, and you can navigate really well into the vessel, and it gives you nice support due to the reinforced shaft. Another important thing beyond the wires is that you can always use several techniques to improve your support. It not depends only on the wire. Obviously, the guide catheter curve, the diameter, or the axis. And there is this very important concept of the relationship between the micro catheter and the wire. And this was put nicely in graphics by Teleflex, where they represent this the distance between the tip of the wire and the micro catheter, and as it goes really close into the tip of the catheter, the tip force increases a lot. So it not only depends on the wire that you select, but also depends on the micro catheter and the distance from the tip of the micro catheter to the tip of the wire, as you can see here. So with this, you can have a lot of options and go with only 3 wires and 1 microcatheter. Depending on the position of the microcatheter and the wire, you can cover a lot of different range of tip load. So in summary, the main question is, what do you want to do with the wire? If you want to do a proximal gap puncture, then use a high tip load with taper such as the Confianza Pro Hornet. If you want to do a knuckle, then a polymer jacket wire, Fielder XT or Pilot 200, and now probably more often with the Gladius. If you want to go intra-plaque, then you can use a Gaia or Judo, or if you want to increase your support of cross-annulation, then you will need to go with a wire that has a reinforced shaft. And thank you very much.
Okay, thank you. It was a very clear presentation and very organized. So yeah, I think it's very useful to know that all these wires for multiple purpose. So once again, does anyone want to make some comment or some question from the panel?
Estás en mute, Nacho.
Yeah, I have a practical question for Ander and then for the rest of the panel, if you want to give your opinion. We have a great family of wires from Asahi, a great family of wires from Boston, and now wires from Teleflex are coming. And also Abbott has a few wires dedicated to CTOs. Do we need all these wires? How do you work? Do you work only with one company to know very well the wires? You select specific wires from every company, which is the best strategy, Ander?
Well, I think it will be the same answer for everyone. You don't need all of the wires, that's for sure. You need to work with the wire that you feel the most comfort, or that the one that you have most experience. But also, and this is true, from time to time, there are wires that can actually give you more things that you don't have with the other family. And that's an example, for example, the Gladius wire. So I think I use, I don't know, by memory, but 7 or 8 wires, because those are the wires that I use the most. But when it comes a new wire with actual difference, then it's important to have this in mind. I don't know, another example will be the Gaia Next. I haven't tried those wires, but I think people are moving, with this new technology. So the brief answer will be no, you don't need all of the wires. You need to work with those that you are more comfortable and that respond to the specific question that you are asking. You want to penetrate, you want to do a knuckle or whatever, but keep your mind open to new possibilities.
Okay.
Yeah. And there, I would like to ask you a question. Also a practical one. Do you change the distance from the tip of the microcatheter to the tip of the wire depending on the wire that you are using, or depends on the step that you are in that moment? I mean, if you are going to do a dissection, you close the tip of the microcatheter to the tip of the wire, and but if you are inside all the length of the occlusion, maybe you change the distance. What is your opinion?
It depends a lot of the feeling, but yes, it can change. Some scenario, for example, if you are trying to track a microchannel with a Fielder XT and you advance a lot the microcatheter, then it's very easy to go subintimal, for example, because you are giving a lot of push to the wire. So in that case, I go with the microcatheter very, very back and try to smoothly advance the wire. But for example, in a very calcified lesion that you advance the wire and it comes like bending, then you need to advance the tip of the wire. Those are very typical scenarios. And then Usually through the occlusion, only if you see that it's not advancing a lot, then because I'm not feeling a lot of, I'm not very comfortable advancing the micro catheter through the occlusion if I'm not sure that the wire is in a good position. So I only advance the micro catheter when I do a knuckle. But if I'm trying to go intraplaque, I don't advance through the lesion the micro catheter to avoid any complication. Yeah.
Okay. Okay. Does anyone have any question?
Yeah, Pedro and Joao, how is the situation in Portugal with wires, microcatheters, which is the most extended material? You use mainly Asahi or how?
Yes, we, well, at least for me, I don't use too much guide wires. I use mainly the ones that Angel was saying in his presentation. I agree that sometimes there is a new wire that you should, and it brings something new like the Gladius, but I use mainly wires from Asahi, and then the Ornate, and I don't have experience with the new wires from Abbott or from Boston. Even Judo, I don't use them. So for me, mainly Asahi and the Ornate one, because it's true that it has a high penetration force that even with the Confianza Pro 12 sometimes you cannot achieve. Regarding microcatheters, the same. I use mainly microcatheters from Asahi, Caravel and Corsair. I think that the new Corsair Pro XS, it's a great improvement. At least I had a couple of cases for retrograde, and it's, for me, it made the difference. I have tried sometimes the Turnpike LP, but I think that this one makes a great difference. And also the Sasuke, I think it's a great option, and I'm using each time more double lumen catheters. I think that it's we went back to parallel wire technique that we almost didn't use some years ago, because we left the parallel wire technique, but that now with this kind of double lumen catheters, I think that we are back to this technique. Well, and in Portugal, we can hear the opinion of João. I think that he's using about the same material. Do you want to?
Yeah, regarding the guide wires, I think you need to know what is the properties of the guide wire and what is the task of the guide wire. This is this combination that we can succeed. This is the most important. Okay, I have the guide wire from Asahi and also from the Boston. Okay, you can compare fielder family with fighter. This is different because fielder, it's polymer ejector, but you can, with the fielder, the fighter, you can have what you have with the fielder, but you have more penetration force, and you have a lot of experience with the fighter through to lumen in the fashion way, very safe. Regarding the Gaia family, it's something the new level, because it's very important guide wire. It's something that move completely our way for treating the CTO, because intraplaque guide wire And I'm very, very good feelings from the new Gaia Next. I think it's something that will be changed completely our way of treating or to do integrated wire escalation. Regarding judo, this is the competitor from the Gaia family. This is not the same. I have a lot of experience with the judo guide wires. It's different. Okay, sometimes you try judo, at the end you do the case with the Gaia and the opposite. Mm-hmm. But I think it's a good guide wire. Also, I think it's I have experience with the Gladius. This is not the same, the Pilot 200. Pilot 200 is a safer guide wire. It's a good guide wire, and you have, and we don't have a very definition of the CTO boarding. It's good for tracking. It's good for knuckle. This is a good guide wire. I'm very experienced with the Pilot 200. And regarding micro catheters, surely I prefer the spin one than the push one. My favorite, this is the Corsair family. This is clearly all the time the evolution, but also we have a lot of experience with the Turnpike family. Sometimes you use the both, and you try a lot with the Corsair. At the end, you pass with the Turnpike Spiral, Turnpike LP. This is the combination also in the micro catheters and the properties and the task of the micro catheters. And I have not a lot of experience with the MAM and the MAM Flex. I tried twice or three times the micro catheter, but it's something different, but I have to go some experience in this field. And when we need the support for the CTO body occlusion, I think the Turnpike Gold, this is my favorite one. I don't have Tornos, because I think it's when you need support and you have a long occlusion, you have heavy calcified the tortuous vessels, and I think you need to do something different, something to work extra plaque safely and to finish the procedure, because we keep in mind the main goals of the CTO, that is the safety for the procedure and for the patient and for the team, the efficiently and efficacy. Sometimes when you take 1 hour, 45 minutes to try integrated wire escalation, fail. I think it's not a good way to do the things you need. The procedure will be proactive. You need to go forward to try different ways to do the CTOs. In long CTO, calcified, and some tortuosity. Probably if you don't have a very good intervention of collaterals, sometimes it's not a good way to work in the integrated wire escalation, because sometimes you are going to change for retrograde. At that point, you are going to tell me we have a lot of complication. This is not a lot of complication. We have a lot of complication because we have taken the retrograde approach as a bailout in a bailout integrated procedure. This is why sometimes you have a lot of complication. Retrograde, if you have a good interventional collaterals, if you have experienced team and you are very experienced with the technique, 30%, 35% of the case, it is the best way to do the procedure.
I would like just to say one thing more regarding microcatheters, because I think it could be a good trip for the audience. Sometimes when I need a more flexible microcatheter, I still use the fine cross. And this happens, for example, in an ostial LAD. Sometimes we are able to engage the ostium, but with a great curve with the wire. And then we need to change the wire with a short band to be able to penetrate. And in this situation, for me, fine cross is very useful because it doesn't make the wire to prolapse. And sometimes we can engage the fine cross in the ostium and then change the wire. And we cannot do this with a Caravelle, which is not so flexible, or even with a Corsair. It's my experience. I don't know if you agree, but I would like to say that.
Now that you mentioned the fine cross, I think I have to ask a difficult question to Sole. because they have a lot of experience with Fancross. The feeling from outside Córdoba is that you were quite minimalistic in the tools that you use, but also that now you are using more tools than you used to. What do you think is the biggest revolution or the biggest change in terms of tools in the last 5 to 10 years, in your experience?
Difficult to
it's
say.
Difficult. The question is difficult.
Difficult to say. Micro Catheter has have developed a lot. I like Fancross because I think it's a very flexible catheter. Micro catheter is possible to navigate adequately for the coronary artery, but we have moved from other micro catheter now. We use the Corsair. TruePi-LP for us is ideal for epicardial collaterals. But I think the main revolution probably are the guide wires. The Gaia family is a point of inflection. Probably the SUO, the guide wires. So I will have to choose. I will choose the Gaia family probably and the SUO.
And Alfonso?
The guide wire, probably. Because now there are a lot of new guide wires, as you have said, the Teleflex, even Abbott has a new guide wire similar to Confianza Pro 12. But I have more experience with Asahi guide wire, and for me, the Gaia family was an important advance, in my opinion. But it's difficult to say. Sasuke is a very good tool, and totally different to other dual lumen catheter due to the navigability, the crossability. But in my opinion, if I have to choose only one tool, the guide wire.
Great.
And also, I think, I don't know if you agree with me, one of the game changers also in CTO procedures have been the guiding extension catheters, or at least we use it because it gives you an extra support because you are going to do a reverse cart. And of course, it's not specifically designed for CTOs, but it really gives you it's a very useful tool and gives you extra support. And we use it in almost every complex CTO procedure.
Yeah,
I agree with you. Basic for most of the procedure, mainly in complex procedure, not only in CTO. I agree with you. In CTO, for us, we use Gaia extension in almost all procedure. In CTO.
I was thinking the same answer for the same question. So Gaia extension catheter for me, obviously the wires, but also the smartest, I think, advancement, in my opinion, is the modified microcatheters, dual lumen microcatheters, and also Stingray as a balloon.
And also
so the concept of ADR, what do you think about the concept of ADR with Stingray? Is a good tool, is very residual, experience today was so and so.
It's a very good tool, is residual because people, or we don't do it a lot, and we reserve it only for the last option, as you said before. But I think it's more easier than tools we use and other techniques.
For me, it's more predictable. If you can try re-enter with the wire base, but if you have device base, it's the best. Probably you don't need to use the crossbus, just Stingray. This is if you have a good selection of the cases, it's very, very easy for you. You don't take a lot of time to try 3-4 different strategies. For me, it's very, very good point. Also, I have some experience with the twin pass torque, because you can rotate the distal profile. This is not the same to Sasuke. Sasuke is one of the best, but some cases where the twin pass tort can add some new devices, new things for you, and to get to finish the procedure. It's very important also. But for the guide extension, I'm completely agree with you. This is for the complex PCI. Okay, again, CTO, it's a complex PCI, not, I think you need to talk not the CTO, the complex PCI. And also the Teleflex, the Chris Bulloff did with the junction with the balloon and the guide extension. Also, it's a very, very good junction, because trapping, it's a good and safe for the safety of the procedure. It's something that I appreciate very well.
There is also a micro catheter, the recross micro catheter, useful to the re-entry technique.
Sure.
Yeah, you don't have to, but is possible a useful tool for this purpose. If you don't have Stingray.
Yeah, regarding micro catheters, this is true, because the tip of the fine cross or the caravel, but this is the problem. And you have a lot of tortuosity if you have some calcified lesion, or if you have some heterogeneity of the vessel. A micro catheter, push micro catheter, is not the same the spin micro catheter. You can do it easily. And safety. I think this is why, and you can go tip in, it's a very interesting thing. And sometimes I think with the spin micro catheters, you can do something more different and safety. This is for me, because I saw some guys doing, they don't want to start with the spin micro catheter, but I think it's someone that you have this is a tool that you can reach, and you can do the way better in safety and efficacy point of view.
So Pedro, if you agree, I think we could move to the talk by Alfonso.
Yes, just before we move to the talk, I would just like, there was a question from the audience that I lost. I'm sorry, and it was a question to Dr. Soledad about his talk, asking if in an ostial RCA CTO she uses to have a CT scan before, just to know or to be able to have to know, yes, where's the ostium, if he finds that to.
Nacho asked me the question. Sometimes yes, useful, because you can know the ostium and the trajectory of the vessel when the trajectory is unclear, but no for routine, only in selected cases.
Okay, thank you.
Or in failed case, when you cannot cross retrogradely and you don't know where is the ostium, but only in selected cases, no in routine clinical practice.
Okay, thank you. So we can now move to the last presentation by Dr. Alfonso about the plate modification techniques, and for which plate modification for which type of CTO. It's his presentation. I would ask him to go forward. Okay.
Thanks, Pedro. Thanks. You can see the presentation?
Yes.
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 Thanks to Nacho and Jose Antonio for the invitation, and congratulate again to the operators of the cases. And also want to thank you all to leave me some space to focus on the plaque modification techniques. So this is the index of the presentation. We'll do some introduction. I will revise some aspects of plaque modification techniques for the audience. I know all the experts know it, and I will finish with a practical algorithm. So when I saw the first time this title, I wonder how many types of CTO I knew regarding the plaque. And probably in this regard, it's interesting to recall that plaque composition is related with the duration of the occlusion. And in short duration occlusions, predominate cholesterol and foam cells. And in occlusions with longer duration, we have hard fibrocalcific tissue and also bridging collaterals and microchannels. We have histological evidence of this. This is a short duration CTO, and you can observe an organizing thrombus in the middle of the occlusion. In the adjacent segments, organized thrombus and collagen and fibrotic tissue in the caps. And when you have a long duration CTO, this is a slide that also Joao showed before, you have 4 characteristics: severe calcification, probably microchannels in some of them, and negative remodeling, as you can see in this picture. So when we are talking about plaque modification in CTO, we obviously are talking about calcium. And CTO and calcium are intimately related. We know that calcification is present in nearly 70% of cases of CTO and moderate to severe calcification in nearly 60%. And all the calcium is not the same. When it progresses with the progression of the occlusion. At the beginning, we have microcalcifications, and with the longer duration of the occlusion, we have more extended sheets, nodules, and thicker plaques, as Pierre showed before. And it's not casual that these are the main predictors of standard expansion. So calcium impacts on the results in PCI of coronary occlusions because it reduces access and it increases MACE. And again, it's not casual that CTO and calcium are on the top of the complexity pyramid of PCI. And calcium reduces access in CTO PCI because it makes this CTO uncrossable in 9% of cases and undelightable in 12%. Probably these are the types of CTO regarding the plaque modification techniques, uncrossable or undelightable. And also calcium reduces access and increase MACE because it increases the complications, mainly perforations, by 10 in some registries. So we will focus on some points of plaque modification techniques now. You know, we have balloon-based technologies and non-balloon-based technologies. Between the balloon-based, we have the NC balloons and even the super high pressure balloons, the modified cutting and scoring balloons, and recently the lithotripsy balloon. And the non-balloon-based technologies, we have the rotational atherectomy, orbital atherectomy, and laser. All of them have different features, but they share one that are all of them under use in every PCI, in overall PCIs, but also in CTOs. If you recall, we have nearly 60% of moderate to severe calcification in CTO, and we are using only in 7% of cases of CTOs these tools. Talking about rotational atherectomy, you know the device, an elliptical diamond crystal coated bar. We have improved the console from the classical one to the RotaPro system that is easier to use, mainly if it's only one operator. And we have used rotablation in several calcified lesions, all of us. But a possible concern that has been remarked previously by Joao is that using this rotational atherectomy in dissected segments or extra plaque segments in CTO lesions. I can show you this paper that compares rotational atherectomy in non-CTO lesions and in CTO lesions. And obviously, CTO lesions are more complex, and obviously, in CTO group, there are more rotational atherectomy in dissected planes. And in these planes, they had a 100% procedure success. And overall, they have a similar procedural success rate than in non-CTO procedures with a similar MACE and complication. I don't have any experience in orbital atherectomy. You know, the device is a little bit different from rotational atherectomy. It's a crown, not a bar. And there is only one size 1.25, and it does an elliptical rotation that not only ablates the intimal calcium, but increases the vessel diameter with the increasing of the velocity, the speed. Rotational atherectomy and orbital atherectomy needs a specific guide wire, the rotor wire and the Viper wire, and it is an issue in some cases of CTO. There are scarce data about orbital atherectomy in CTO. I have found this paper of the Progress CTO Registry combining the two techniques, rotational and orbital atherectomy. They are used in 3.2% of CTOs, 105 cases of rotational atherectomy and only 8 orbital atherectomy. And they are used always in more complex procedures with similar technical procedural success and MACE than in non-atherectomy procedures, but with a higher rate of complications. And it's similar to the data of previous series. The other non-balloon based technology is laser. You know, laser is the acronym of light amplification by stimulated emission of radiation, and the energy is produced by an excited dimer. The dimer is xenon chloride. We excited the dimer applying a high voltage discharge, and when the dimer drops to the ground level of energy, a photon is born, and this photon produces energy in the ultraviolet range in a very short pulses. In every nanosecond, billions of molecules are broken, and it's a quite safe technology because the absorption depth is only 50 microns, less than previous lasers, and the products of ablation are minute enough to be cleared by the reticuloendothelial system. The mechanisms are mainly three: the photochemical, photothermal, and photokinetic. I'm not going to focus on this in this presentation, but you should know that LK catheter is quite easy to use. It's a catheter with different sizes, but we mainly use 0.9 or 1.4 millimeters catheter, and we can use it by every conventional guide wire of 0.014, and this is the main advantage in the CTO procedures. You can use by 6 French guiding catheter, and LK has been used in different scenarios, even in CTO, and we use in CTOs when they are uncrossable and or undilatable. When we are talking about uncrossable lesions, I have this example. It's not an anatomic CTO, probably a functional one. We cross it with a Filtrex TA wire, but albeit having an AL1 guiding catheter and a guide liner just proximal to the lesion, a 1.0 balloon couldn't cross the lesion. So we perform LK, a 0.9 millimeters catheter with these parameters. And after LK, you can see here the LK advancing so slowly through the plaque. And NC balloon 3.0 could cross easily and implant an stent. In the Progress CTO Registry, as I told before, 9% of CTOs were uncrossable. They were the more difficult occlusions. And laser was the technology most used to solve this situation and the most successful one. In this series published by Soledad of uncrossable lesions, more or less half of the sample was CTO lesions. As you see, severe, moderate to severe classification in 62% of cases, with technical and procedural success near 90% of laser. And when we focus on undilatable lesions, we think about standard expansion, external stenosis, calcified lesions, CTOs, but we have to bear in mind that calcium is almost always there when the lesion is undilatable. And I have this example of this ostial CTO is even in stent restenosis, and stent implanted in 2003. The occlusion was crossed with a Progress 40 wire and predilate with growing size balloons, but without clear expansion of them. So we performed laser with a 0.9 millimeters of catheter, and after that we could cross NC 3.5 balloon, dilate, and complete the procedure. When we focus in series regarding balloon and dilatable CTOs, the procedural success rate is near 90%, and probably is a little bit higher even than in balloon and crossable lesions. So this is an option, mainly when you cannot cross a microcatheter, to exchange the wire to a rota wire or valvular wire to use other atherectomy devices. Moving to the balloon-based technologies, we have the cutting and scoring balloons. You know that these are balloons modified with microblades or spiral struts around the balloon that modify the plaque and make them more compliant. And we have different devices. Probably Blimp is one specific scoring balloon for CTOs. It's a very small scoring balloon intended to create an initial opening in heavy calcified occlusion. You can achieve high pressures. So it's a good option. And there is scarce data again of the use of these balloons in CTOs, but they have been used with a good technical and procedural success. An original use of these balloons in CTO is shown in this case, a recurrent artery CTO, quite ambiguous proximal cap. We perform a direct retrograde approach and cross easily through a septal collateral. We struggled a lot to connect the proximal and distal gear, but after that we could externalize a wire, as you can see in the video. We predilate all the lesion, implant the stent, but after implanting the stents, we obtained this flow. Obviously, we checked with IBUS, and IBUS, as you are suspecting, showed a huge hematoma at the end, at the distal edge of the stent. You can see here the hematoma. And we decided to use a cutting balloon just at this point. And immediately after inflating the balloon, the TMC flow was recovered. So we decided to implant an stent with good final result. And the other balloon is the super high pressure balloon. It's a dual plastic layer balloon that can achieve high pressures. And again, it has been used in resistant lesions, 20% of cases of CTO with good results. There are not so much data about that specifically in CTO. And finally, lithotripsy is the new technology. We have it since 2 years ago. And lithotripsy has evolved the technology that we use to break the urinary stones for breaking coronary calcium. This is the technology for the audience that don't know it. This
waves into the vessel wall to reach the calcium.
A balloon that is inflated at 4 atmospheres inside the plaque, and we apply the pulses,
through the connector,
converting the electrical energy in mechanical energy.
Once per second.
As you
While
can see
other
here in the video.
treatments can't differentiate between calcium and soft tissue, acoustic pressure waves pass through soft tissue to impact both intimal and medial calcium, with emitters along the length of.
Okay, and you have diameters from 2.5 to 4 millimeters. There are some potential advantages of lithotripsy, as you know. One of the most important is that it doesn't need a specific guide wire. It is selective for calcium. It can break deep calcium, not only intimal plaques. It reduces the risk of distal embolization compared to atherectomy devices because it only creates fractures inside the plaque. You don't need high pressures in the balloon to modify because of the design of the device. You can protect a side branch with another wire, and more important, it's very easy to learn compared with other atherectomy devices. It's useful in eccentric and concentric calcium, intimal and medial, thin and thick. So it's a game changer in complex PCI for sure. So this is a case of IVL in CTO. We had this recurrent artery CTO. We plan to perform an integrated approach with a dual lumen microcatheter with a wire in the acute marginal branch, but we encountered some friction advancing the dual lumen microcatheter. So we decided to treat previously the proximal vessel, but the balloons, as you can see here, found a severe under expansion. So we performed IVL there with a guide extension catheter, implanted 2 stents, and afterwards you can see here the IVUS previous of the shockwave balloon with severe calcification. And after implanting the stents, we could advance the guide liner, a dual lumen microcatheter, cross to the true lumen, and finish the case. Regarding the concerns of Joao of doing lithotripsy in intraplaque or extraplaque, I don't have the answer, but I have found some cases of doing reverse cut using a shockwave balloon because of the previous failure of conventional balloons. But indeed, there are complications of doing lithotripsy in the subintimal space. Probably it's easier to have a perforation. We have to take into account. We have evidence of lithotripsy in PCIs, in overall PCIs. However, these pivotal studies did not include CTOs. And searching in real life registries, CTOs are present in 7% of cases. And yesterday, I found a really fresh article published this week that is probably the first lithotripsy series in CTOs published by very expert operators. The CTO of this series, 55 patients, were quite difficult. As you can see, IVUS in 90% of cases. And probably the main point to remark in this series is that IVL was associated with another plaque modification technique in all the patients. And it led me to introduce the last techniques, the combinations of plaque modification techniques in CTOs or in general, rotacutting, razor, rotational atherectomy, and laser. And as you can see here, CTO PCI is the main predictor of needing razor for these procedures. Rotatripsy, obviously, if you have a thick calcium plaque, you need shockwave to expand the stents, but probably shockwave balloon is not going to be delivered to the lesion. There is a CTO or a critical lesion, so you need to create a tunnel with rotational atherectomy, for example, that only ablates the intimal calcium, and as you can see here, the ablation of the rotational atherectomy, and shockwave finish the work producing the deep fractures. Sometimes, mainly in CTOs, you can't do rotational atherectomy because even a microcatheter cannot cross the lesions, and you can't exchange the wire for the rota wire. So this combination that we have published recently is another option, mainly in CTOs, doing the tunnel with laser and completing the work with shockwave balloon. So what is the most used technology in CTO? It depends. It depends the availability, the experience of the operator, and the series you are seeing. Probably balloon-based technologies are most used, mainly NC balloons or high-pressure balloons, followed by rota, laser, cutting, and IVL. But obviously, it has a bias because IVL has been recently available, so it will be changing in the future. So my practical algorithm must take into account all the things that Joao said before. There, we have to consider not only these technologies, but also techniques, increasing the support, granuloplasty, Carlino, etc. But talking only about technologies, this is my proposal of algorithm. If the wire crosses the CTO, I used to advance a microcatheter and exchange for an extra support guide wire and try to predilate with a small balloon and perform IVUS. If the microcatheter does not cross, laser. If the balloon does not cross, laser and IVUS. And after that, with IVUS, we check the occlusion. And if there is not severe calcification, probably you can go with NC balloons, cutting, or scoring balloons. If the expansion is optimal, you can go for the stenting and optimization. If it's not optimal, probably you need IVL, lithotripsy. If the calcification in the IVUS is severe, the next question is if you have thick and deep calcium. The answer is yes, you need lithotripsy. Probably in a CTO, a shockwave balloon is not going to cross. So if it's so, you need rotatripsy or elcatripsy. And if deep calcium does not exist, probably you can use rotational or orbital atherectomy. If the dilation with the NC balloon afterwards is optimal, you can go for a stenting. If not, probably you need rotatripsy as well. So to conclude, moderate to severe calcification is nearing 60% of CTOs. Plaque modification devices are used in 3 to 7% of CTOs. And the choice of these techniques depends on the availability, the experience, the type of CTO, if it's uncrossable or anidotable or both. And combination of these techniques are frequently needed. Plaque modification techniques in CTO achieve high procedural success rate and similar MACE than in non-plaque modification CTOs. And CTO operators should be able to manage technology and also these techniques to achieve the best results in their procedures. Thanks for your attention.
Thank you very much. Very interesting presentation. Let's hear from the panel. Does anyone have any question?
Yes, I would like to ask Alfonso, congratulations for the presentation, by the way. It was a very thorough review. My question is, do you think the orbital atherectomy could have any advantage over rotational atherectomy, or in which type of lesions? I mean, not only CTO lesions, but in complex angioplasty. Do you think it has an advantage over the other, or in which type of lesions?
To be honest, I have no experience in orbital atherectomy. I have attended some courses, and the opinion of the experts, probably without much evidence, is that when you have a very heavy calcification, it's not the best option. But probably you have a very big vessel and you need ablation, and even gaining diameter probably is a good option, but I don't have any experience.
Mm-hmm. Yes.
Yes, I would like to mention something. Recently from the Iberian Registry, that is who is organizing all this meeting, we just collected some information on these cases. And if I may share, this is going to be published in the next few weeks in the Spanish Journal of Cardiology. And as you see now, this document, this is the summary. In the registry now we have more than 2,000 patients. And in 1900, the crossing the CTO was successful. And plaque modification techniques were used in 7% of the patients, as you can see. Well, more than 1/3 was rotational atherectomy, but there are even more cases with laser than with lithotripsy, and a lot of cutting and scoring balloons. OPM balloons, I think they are more often used, in fact. And these patients were actually very sick patients, much more than those where we did not need to use this technique. But as you can see here, the mortality was comparable with those patients that don't require plaque modification techniques, which means that there is like an additional value in the prognosis of these patients if we treat it better. And when we did follow-up of our patients, we are doing angiographic follow-up in our patients, and there is a high rate of angiographic events, not clinical events. But if you check by angio your patients, there is a lot of cases of underexpansion. I think we are underusing these technologies, particularly lithotripsy. I don't know what the panel thinks.
No, I mentioned in the talk of your article, Nacho, the Plankton, our article, and in Spain, the Iberian Registry, the percentage of use of this plaque modification is even higher, double than in the American Registry. They use in 3.2%, and here is 7%, and I think the same than you is underused. So probably we have to change our mind and do a lot of intracoronary imaging and optimize the procedures.
I think the most important point is when you are going to reopen the vessel, and the probably 99% or 100% is properly stenting implantation. This is what can change the long-term prognosis for this patient. To achieve this goal, you need to do intravascular imaging. Came back to your case, Nacho. Could you imagine how calcified was your right RCA? Could you imagine? It's amazing.
Not
Angiography, it's not a good tool to define the calcium, because calcium it's the worst prognosis for the patient. This is the stenting, the properly stent implantation. You need imaging for TV. You need experience. You need imaging, and you need extensive plaque modification technique, not just in CTO, but in complex PCI. If you want a very good results in left main, okay, in IVUS, imaging and the plaque modification. Bifurcation, the same, calcified the vessel. Okay, in CTO, this is the same, because you know, more than 70% of the case you have calcium. It's not good. If you sometimes you are going to start with it's a small right, small LED, but at the end you are going to implant 3.5 or 4 stenting. We know, because we did do a lot of imaging. RCA is more than 4, and you need to stent that vessel properly. If you are going to anticipate the best prognosis for the patient. For me, this is key point of the interventional cardiology, not just in CTO, but in interventional cardiology in general. And now you have a very good tools, and surely that the majority of the guys that embracing a CTO program or cheap program, this is a very experienced operator. This is the key for the success of the program.
Well, I think, yes, I believe that shockwaves is a very useful tool. Well, because all the things that you already said, deep calcium will not be ablated with autoablator. So I think it's a very useful tool. And calcium is one of the things that I most fear in PCI. So I was very, very happy to have shockwaves, but it's true that it's a quite expensive tool. We use sometimes in my hospital, but we till now we had to make a special requirement for each patient that we have to treat. I think that we will solve this shortly, but it's quite expensive. Yeah, another tool
Pedro, just a question. It's just a comment. It's a pen. If you are going to use 7, 10 balloons, at the end, if you use IVL, this is not the deal. This is not very important. And after that, you need to use a guide extension, because all of these tools you need to keep in mind, and you use these tools properly. We need the best for the patient. If you need the best for the patient, you need to be prepared. You need to have a very good toolbox, and you need to have the right skills. Okay, this is my comment.
Okay, I agree, and mainly in proximal regions where you can easily cross with the because the shock waves in distal lesions can be difficult to
you can guide liner, guide extension, assist the shock waves. This is very important. This is safety.
Namely, in the left main, it allows you to prepare nicely the lesion, and it's usually easy to cross. I agree. But what I was saying that I think that we are also using not too much OPN, and it can be also a useful tool. Sometimes you can solve the problem with OPN, and it's much less expensive. And it's my comment.
I'm agree, but the profile is not the same.
No.
Yeah.
It's not the same.
Another point is that I think that there is no technology that is more expensive than a badly implanted stent. So probably we need to focus on that when we are facing our hospitals to have this technology.
Yeah.
The problem is that often we need to use them after the stent is implanted because we try to avoid using them in a CTO. And then you have to treat the stent with the polymer just implanted with an intravascular lithotripsy. And we don't know the long-term effects of that.
Yeah.
I don't know if we are increasing the risk of
Use
stenosis.
laser.
But with laser, probably you are damaging also. I'm not sure. Is it?
I'm not sure, but the company says that it's safe. So
We
don't
don't
have
have
American company.
Don't have data.
No. It will be very interesting to collect these cases where we have used intravascular lithotripsy immediately after stent implantation and see what happened to those lesions at 2 years follow-up. We can start a new study out from your talk, Alfonso.
Perfect.
Pedro, I think since we finished the cases earlier, I don't know if there are questions from the audience, and if there are not, maybe we could.
I don't think there are any questions from the audience right now. So I think we are ending, and so I would like to ask you, you and Jose Antonio, to make the final comments. I will once again like to thank you for this kind of invitation. I'm very glad to participate in this meeting. It was a great meeting. Once again, I think we learned a lot, and I think it's very important to share our experience with our Spanish colleagues. We have a long experience working together with the Spanish centers, and it's always a great pleasure. Thank you.
Thank you, Pedro. So I will say goodbye before Jose Antonio, and thank you very much to all the panelists, all the experts that have helped us during the cases. All your comments have been really helpful because as you saw, we took many decisions based on your advices. We are not worldwide experts, and this is why this is so educative, because we are learning in every case. This is the spirit of the Iberian Registry of CTOs, and this was the spirit of this course. We hope to continue next year and hopefully see you face to face. And just thank you very much again to all the panelists, to all the audience, to ViewLab and Med&Home for the visuals, for the visualization, and to all our teams here in Valladolid and Puerta de Hierro, because it's always very challenging to have a live case like that. So thank you very much to all of you. Jose Antonio, please.
Yes, well, I have an ambivalent feeling because we failed in doing the cases, but I think the aim of the webinar that was to teach people that want to learn how to do complex cases. I think we have achieved that aim. We have had an excellent panel. The presentations were excellent. The comments, they have a lot of experience, and they have given us very good advices. I have to congratulate Pedro for his job, because it was a difficult job. He has to coordinate both two cases at the same time, the panelists, comments, the questions from the people, from the audience. So congratulations, Pedro. You really did a very good job. And I also want to say thank you to our sponsor, World Medic and Boston Scientificus, because these webinars and these meetings are possible thanks to their support. And well, nothing more. I think.
And see you next year.
See you next year, I hope. Yeah, I hope so. So thank you very much. And goodbye from Valladolid and Madrid.
Bye-bye.
Bye.
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 Bye-bye.
Bye, everyone. Thank you.